Hi, my name is Matt Kirsche, and I'm a pediatric neurointensivist at the Children's Hospital in Philadelphia. And today we're going to talk about the ethical dimensions of diagnosing disorders of consciousness and predicting recovery after acute brain injury. I have no relevant disclosures for this presentation. We're going to start by reviewing the spectrum of disorders of consciousness, and then we're going to talk about ethical issues when managing patients with disorders of consciousness. And we're going to do that by treating acute brain injury along the continuum of care from pre-injury to the various stages of managing the brain injury through rehabilitation and reintegration. And we're going to look at the ethical issues of respect for persons, beneficence, autonomy, and justice. Before we talk about disorders of consciousness, we need to define consciousness itself. Conscious behavior requires you to have two things: wakefulness and awareness of oneself and the environment. And acute brain injury disrupts these mechanisms and can lead to disorders of consciousness. There are several different categories of disorders of consciousness that we need to think about with respect to the degree that the patient has wakefulness and awareness of themselves or their environment. We first talk about coma. A patient who is in coma is in a state of complete unconsciousness. In that state, they have no wakefulness and no awareness. Patients who are in a vegetative state or have unresponsive wakefulness syndrome, they can have spontaneous eye opening, signaling that they do have wakefulness, but there is no evidence that they have any awareness of themselves or the environment. We say that when a patient is in a vegetative state or has unresponsive wakefulness syndrome lasting for more than a month, that they are in a persistent vegetative state. And if that condition persists for greater than 3 months, then we say they are in a permanent vegetative state. For patients that have traumatic brain injury, we wait until after 12 months before saying that their vegetative state is permanent. And then there is the minimally conscious state. Patients who are in a minimally conscious state, while they still have severely altered consciousness, they have evidence of wakefulness. And although it can be subtle and inconsistent, they do have evidence of awareness of themselves and their environment. Now we're going to turn to some of the ethical issues in caring for patients with disorders of consciousness, and we're going to do that by looking at the continuum of care: pre-injury, hyperacute, acute injury, through subacute care, early rehabilitation, and then through further rehabilitation and reintegration into their prior life and society. Now, some of these ethical issues happen even before the brain injury occurs. When we look at things like social determinants of health, there are certain populations that are at higher risk of acquired brain injury. Certain insurance status can make you predisposed. Are you in a rural versus urban area? And that is important when we talk about distance to a trauma center. And do patients have access to preventative care prior to their injury and rehabilitation after their injury? At the time that the brain injury occurs. So we know that there are various etiologies of brain injury. Some of those etiologies are very obvious to recognize. Other etiologies, such as stroke or sometimes subtle hemorrhages, may be more challenging to recognize. So one, can the family and the public recognize it? Two, depending on what situation you're in, are witnesses willing to act? There are many systems issues that are influenced by both patient and community factors that are relevant at the time that the brain injury occurs. What is the EMS response time? When EMS arrives, do they have timely recognition of the brain injury? What is the quality of care at the local or the first presenting emergency department? Are they able to request a transfer to an institution that has a neuro ICU? What is the time of that transfer? Another relevant issue is, does a patient have an advance directive, and are healthcare providers able to identify where that is and what it says? When we talk about the ICU care of patients with acute brain injury, this is often defined as the first 28 days after their injury. Once in the ICU, it is essential to make an accurate diagnosis and provide neuroprotective management that follows evidence-based guidelines. There are always issues of ICU capacity and resource allocation, in particular when we talk about patients with acute brain injury, and especially if there's prognostic uncertainty. Prognostic uncertainty is so important after acute brain injury, especially when the patient has a disorder of consciousness. We must be able to not only identify that prognostic uncertainty, but we must be able to communicate that prognostic uncertainty both to other healthcare providers and to family. In order to do that, we need to identify surrogate decision makers. We need to talk about the role of neuroimaging and electrophysiological tests in terms of identifying the disorder of consciousness and helping with neuroprognostication. And in doing so, we also need to avoid our personal and systemic biases. Taking care of these patients can create a lot of moral distress for staff, and support systems need to be put in place for staff, but also for family, given the impact that acute brain injury can have, both acutely and then looking forward into the future. These patients with disorders of consciousness often transition from their acute brain injury into subacute care and rehabilitation. We often define this as occurring after the first 28 days from injury, and often at this point in time, the patients are transitioned out of the intensive care unit. And here we need to focus on diagnosing the disorder of consciousness in and of itself. Diagnosis needs to be accurate, it needs to be timely, it needs to be consistent. We need to make it with the best certainty that we have, and we really need to enhance our prognostic ability by using as many diagnostic and recovery scales and tools as we can. There is a entity called cognitive motor dissociation, or referred to as covert consciousness, and that is a situation where a patient may retain some consciousness. However, due to their brain injury, they are unable to motorically or in other ways physically express the fact that they have retained consciousness. There are a variety of advanced technologies like functional neuroimaging and EEG that can be used to identify if a patient has cognitive motor dissociation, and may be able to be used for things like pain assessment or to identify patient preferences. There are ethical issues with respect to whether patients have access to brain-focused rehabilitation. Questions arise regarding resource allocation and effectiveness of therapeutic interventions when patients get to rehab. We defined earlier that a chronic disorder of consciousness for non-traumatic injuries is greater than 3 months, and for traumatic injuries is greater than 12 months. And it's important to acknowledge that patients with disorders of consciousness, even if they progress along the road to recovery, have lifelong cognitive, motor, and emotional impairments. These patients have ongoing needs for their activities of daily living. We have to talk about access to services, improvement standard, financial burden. Social reintegration can be challenging. And in addition to the patient themselves, there are caregiver burdens and mental health considerations for the caregivers. As we progress over time, we need to have discussions over how to manage intercurrent and future illnesses, and then have discussions around medical and legal decision-making capacity for these patients as they progress on their road to recovery. So I recognize that was a whirlwind tour of ethical issues surrounding disorders of consciousness. It's important to know that these disorders of consciousness represent a spectrum of conditions that can occur after brain injury. There are unique ethical issues at each stage along the continuum of care, from pre-injury to rehabilitation and reintegration. And ongoing research and provider education is needed to improve not only our diagnostic and prognostic tools, the systems of care along that continuum that we use to care for these families, and we need to find ways to improve our communication with families, especially when we talk about prognostic uncertainty for patients with disorders of consciousness. Thank you very much. I appreciate the opportunity to talk with you today and look forward to ongoing conversation. Thank you very much.